Welcome, future psychiatric mental health nurse practitioners. Today we're diving deep into the complexities of anxiety disorders. We'll distinguish between normal stress and pathological anxiety, focusing on what you need to know for your clinical practice and the boards. Anxiety disorders are the most common mental health conditions in the US, affecting nearly 19% of adults annually. Neurobiologically, anxiety involves a hyperactive amygdala and a hypoactive prefrontal cortex, leading to impaired emotional regulation. The HPA axis also plays a critical role, where chronic stress leads to sustained cortisol release and autonomic nervous system arousal. Key neurotransmitters include GABA, the brain's primary inhibitory signal, which is often deficient in anxious patients. Dysregulation of serotonin and norepinephrine pathways also contributes to the physiological symptoms of panic and worry. Genetic studies suggest a heritability rate of approximately 30 to 40% for most anxiety-related conditions. Now let's look at the DSM-5-TR criteria. As PMHNPs, your diagnostic accuracy is the foundation of effective treatment. For generalized anxiety disorder, the hallmark is excessive, uncontrollable worry about various events for at least 6 months. Patients must present with 3 or more somatic symptoms, such as muscle tension, fatigue, or significant sleep disturbances. Board Pearl. GAD frequently co-occurs with MDD. Always screen for both using tools like the GAD-7 and PHQ-9. Panic disorder is characterized by recurrent, unexpected panic attacks without an obvious trigger. Physiological symptoms can be so severe that patients often present to the emergency room fearing a myocardial infarction. Remember for boards, diagnosis requires at least 1 month of persistent worry about having another attack. Social anxiety disorder involves an intense fear of being scrutinized or negatively evaluated in social or performance situations. This goes beyond shyness, often leading to significant impairment in academic or professional settings. Specific phobias are marked by irrational fears of objects or situations, leading to immediate anxiety and active avoidance. Differential diagnosis is crucial. Rule out medical causes like hyperthyroidism, cardiac arrhythmias, or excessive caffeine intake first. Moving to management, the gold standard for most anxiety disorders is a combination of psychopharmacology and psychotherapy. SSRIs and SNRIs are first-line treatments. Educate patients that it may take 4 to 6 weeks to see the full therapeutic effect. Board Pearl. Always start at half the usual depression dose for anxious patients to minimize the risk of an initial increase in anxiety. Benzodiazepines are effective for acute symptoms, but should be used sparingly due to the risk of dependence and tolerance. Avoid long-term use, especially in the elderly, as they increase the risk of falls and cognitive impairment. Buspirone is a non-habit-forming option specifically for generalized anxiety disorder, though it is not effective for panic disorder. Propranolol is a high-yield pearl for performance-based social anxiety, taken 30 to 60 minutes before the event. In psychotherapy, cognitive behavioral therapy is the most researched and effective modality for anxiety. CBT focuses on identifying and challenging distorted thought patterns and slowly desensitizing patients to their fears. Exposure therapy, particularly for phobias and social anxiety, helps break the cycle of avoidance that maintains anxiety. In your practice, use standardized tools like the GAD-7 to track progress and adjust your treatment plans objectively. Never underestimate patient education. Reducing caffeine, improving sleep hygiene, and regular exercise are vital adjuncts. Mindfulness-based stress reduction and deep breathing exercises can provide patients with immediate tools to manage arousal. Let's test your knowledge with a few board-style questions. Here is your first one. A 28-year-old female presents with 7 months of excessive worry and muscle tension. What is the most appropriate first-line medication? Is it A, alprazolam, B, sertraline, C, propranolol, or D, quetiapine? Take a moment to think. The correct answer is B, sertraline. SSRIs are first line for GAD. Alprazolam is avoided for long-term use, and propranolol is for social performance anxiety. Next question. This one focuses on diagnostic distinctions. A patient fears being judged while giving a presentation. Which neurotransmitter is most likely implicated in their acute physiological response? Is it A. acetylcholine, B. norepinephrine, C. histamine, or D. melatonin? The answer is B. norepinephrine. It drives the autonomic fight or flight response seen in acute social anxiety situations. To summarize, focus on the DSM criteria, understand the GABA and HPA pathways, and always combine medication with therapy for the best outcomes. Good luck with your studies and your upcoming certification exams. See you next time.